Good afternoon, everybody. It's good to see you all, many old friends in this audience. Is this a great group that has put this together and been supported by the faculty? And it's just an exciting day for us to start something this historic. And we'll look forward to this going forward. You know, COVID changed everything, didn't it? It gave us a whole new appreciation for what we can do virtually. And Dr. Griswold reminded me when he stood up that Dr. Griswold himself is a pioneer. He pioneered burn care using telemedicine before it was a thing. And thank you for that. He's received some awards for that. And we're grateful for what you've done on that, John. Thank you. Yes. We have, seeing the slide of the board and all the students made me realize how many times over 2 years we all looked into those screens. And I don't know about you, but I always wished I could hug on a few of the people that I would see across those screens because they were good old friends and hadn't seen them. Don sitting right there, one of them. Isn't it great to be back together again? Isn't it just great? If you think so, let's just give a hand. And you know, if you stick around long enough, you get a chance to introduce another old friend. And that's my task here today. I'm glad to introduce John Henderson. John and I have been on programs together. I've been in programs with him that he has planned. He's been in programs I have planned. The Institute nominated him several years ago for the Rural Health Champion in Texas, and he was selected for that honor. I'll never forget the speech he gave that day. At that time, he was the CEO of Childress Medical Center, and he was a pioneer also because we had just instituted a telehealth program that supported your cancer effort. And Dr. Kobos would make trips up there and then see patients in the interim across the virtual platform before anybody else had done that. So we're really glad that John has done that because it prepared him to go to Austin to become the CEO of TORCH. TORCH is the Texas Organization of Rural and Community Hospitals, and its membership is 161 critical access small rural hospitals and PPS hospitals that are the infrastructure that we depend upon in West Texas for health care. We have actually testified together in Austin. They went first, I went second. We always talk about what we export, and you know some of these things. Certainly cotton, oil, gas, beef, mohair, intellectual capital, because some people go that way for training and don't come back this way. I'm not saying that that's a good idea. In fact, I'd like to see you all come back this way. But also ad valorem taxes, and that's why we have to keep this workforce going. We produce 40% of the economy of the state, and we have to have a strong infrastructure to do that. John has been battling the good battle down there. The membership of TORCH has been effective, and we're just grateful that he's here. He is actually a triple alum. He could talk at UT, he could talk at Abilene Christian University, and he took his MBA right across the street at Rawls, but did all of his work right here. So John is not a stranger to us. He will inspire you. He just got through with his annual meeting. I had the pleasure of attending that meeting. And let me tell you, if you have a chance ever to go to a TORCH meeting, particularly the spring meeting, go do that, because you'll meet there the people who are on the edge of healthcare and setting the tone for what the future should be like. John, we're glad to welcome you home, sir.
Thank you, Dr. Phillips. And it really is great to be with people and good to be back in Lubbock. It's actually my privilege, if I'm thinking about this correctly, I'm the first speaker at the first annual West Texas Health Disparities Symposium. That's kind of cool, right? And he mentioned it. I did my graduate work here and split my time between the business school and the Health Science Center about 25 years ago. So I got kind of nostalgic driving back in. I looked for Conference Cafe. I don't think it's there anymore. I actually lost a bet in 1996 at the Conference Cafe, and thankfully there was not a tattoo parlor open in Lubbock after the World Series, or I would have a giant New York Yankee tattoo on my butt. But I avoided that narrowly. I don't think it's open. I know, is Spanky's still here? We used to go to Spanky's. Is Lone Star Oyster Bar on 34th Street still a thing? Probably spent more time there than I did at the library, but lived to tell about it. And it really is good to be back here with you today. Dr. Griswold, I'm not sure that I'm motivating or innovative in any particular way, but my heart is for rural health. So I wanted to spend some time with you today talking about rural health disparities, actually on one level, and then even within rural populations, how we have disparities that we've got to do better at around race and gender and other demographic distinctions. So I actually want to start there. And I love telling stories. I'd love to get up here and tell you an anecdotal story about how someone fell through the cracks and we should be able to do better. But I don't think that's what the disparity conversation today is about. I don't think it's anecdotal. I think it's systemic. And let me kind of explain that. And when I say systemic, I'm not talking about in any broad term around racism. If that exists, it probably does exist, but I haven't encountered that in my career. I'm not talking about anything conspiratorial. I'm talking about what we were actually visiting about before the conference got started, is what we tend to do is try to find solutions to urban problems, and then whatever works, we lay over the top of rural communities and hope that it'll work. And what I've found, at least in my experience, is that generally doesn't work at all. Rural is not a smaller version of urban. But what works in Dallas or Houston may or may not work in Childress, Texas. We've got to find, and it's not that Childress, Texas is better or worse. I would argue that it's better, but that's my personal bias and point of view. Actually, my mom, who's from Childress, my parents were high school sweethearts in Childress, she says, if you stay in West Texas long enough to wear out a pair of shoes, you'll never leave because the people are so good. And I actually broke that by moving to Austin about 5 years ago. I didn't live up to my mom's motto, but she talks about how good the people of West Texas are. So they deserve to be treated well, and we shouldn't have disparities around either urban v. rural or within a rural population based on your demographic group. So I want to talk about that today, starting with just some rural hospital 101, not specific to West Texas, but specific to Texas. I will admit up front, I'm going to get you out on time, but probably the majority of my hour is going to be negative and problem oriented, and I'm sorry to do that. I hate being that way. I'm actually a glasses half full kind of guy and bullish about rural Texas, but we're going to spend a lot of time talking about problems and trying to frame those up, and then hopefully towards the end of my presentation, we'll get to solutions. I said I'm from Childress, but I moved to Austin about 5 years ago. By show of hands, how many of you grew up in rural communities? Do y'all know what's your definition of rural? Like, keep your hands up. If you grew up in a town less than 50,000, hands up. All right, 25,000. 10. 5. We're down to 2. 2,500. I'd met you. You're from Culberson County, Van Horn. Where are you from? I don't even know where that is. Where's Walton, Texas? Okay. And where is Walton in proximity to a place I'd recognize? Got it. This is a map of Texas. My claim to fame is I've been to all of the rural hospitals in Texas. But I continually meet people that say, I'm from Walton, do you know where, and if there's not a hospital there, generally I don't know where it is. The state definition of rural, the Medicaid definition, is county population of 60,000 or less. By that criteria right now, Dr. Phillips said 161. We've had a few closures. We actually count 158. In the legislative session, today is actually day 132 of the 140-day session, not that I'm counting. No, it's day, there are 32 days left, so what is that? 108? 108 of 140, 32 days left, and I'm tickled to have a reason to be away from Austin and be with you today. But 155 of those 158 that we count currently, it would be 161 if the state raises the threshold to 70,000, which they're considering doing. That would bring in Decatur, which is Wise County, Lake Granbury, which is Ford County, and Marshall, Texas. I'm actually not sure what county that is, but they're within 65 and 70,000. This is a map of those hospitals. You can't see it, but red dots are critical access hospitals, which are those that get a preferred reimbursement from the federal government in traditional Medicare. The green dots are rural PPS hospitals that are the bigger rural hospitals. And then the map is color-coded based on whether or not they deliver babies. So blue counties are rural hospitals that still provide OB services. Flesh-colored counties are hospitals that don't. Yellow counties are counties without a hospital. And clear or white counties are urban, if that makes sense. This map is just our attempt to give a visual representation of what we call maternal deserts, right? And actually, Dr. Billings knows more about this than I do through his practice in Alpine and Presidio. That county is actually a blend because of some things that they were actually part-time at one point doing Monday through Thursday OB. Now I think they've restored the service. The other examples in your neighborhood up in the Panhandle, Gray County, which is Pampa, recently gave up OB services. And then out in far east Texas near the Louisiana border, Jasper, Texas, has a hospital. It's a Christus hospital, but they no longer provide OB services. And now they are serving 5 counties that don't deliver babies. A generation ago, 60% of rural hospitals had OB services and 40% didn't. Today, it has flipped. 40% do, 60% don't. So we're seeing this growing maternal desert situation. Actually, there's a great article, if you want to Google it, in the Texas Tribune about the situation in Jasper. They were talking about not just when you're in labor and deliveries, but even prenatal visits. They were going 70 miles to Nacogdoches or by ferry to Galveston. And if you think about being in labor on a ferry, I mean, nothing gets much scarier than that to me. 121 of our hospitals are trauma designated, mostly as level 4, a few level 3, but mostly level 4. And then, as Dr. Phillips said, the majority of our members are critical access hospitals. Y'all have any questions there? This is a study that the Texas Hospital Association commissioned about overall hospital vulnerability coming out of the pandemic. And the headline was that 10%, 9 or 10% of Texas hospitals are vulnerable to closure. But to me, what was more interesting is that graph on the right-hand side that breaks it urban-rural. It's 26% to 5. So rural hospitals are 5 times more likely to close than their urban counterparts, and probably more vulnerable to closure on this side of the pandemic. We thankfully haven't had a rural hospital closure in more than 3 years. The last one was in Montague County in Bowie, Texas. This is the NRHA map, National Rural Health Association map of closures since 2010, or actually it goes back a little bit further than that. They count about 130 in the last decade. What's interesting to me is the geography of that. You can see Texas, mostly East Texas, not as much out here in West Texas. Actually, the furthest west that I'm aware of was in Hamlin, Texas, or Stamford, Texas, down around Abilene. Hasn't gone further west yet. I can't prove this, but my theory is that as you go further west and you have property values tied to oil and gas, and tax revenue, ad valorem tax revenue in Texas, that has been protective or sustaining of those hospitals in West Texas that we haven't seen in areas of East Texas. But they aren't immune to closure. These are rural. I'm going to show you a few national slides real quick just to show you something. We call it death by 1,000 paper cuts, the things that contribute to a rural hospital closure. You can make a list. But this shows the closures, and as you can see, they're kind of concentrated in South and East. Population decline is what, to me, drives the pharmacy closures. Those are the yellow counties that basically go through the Midwest portion of the United States. And then this is nursing home closures. Same thing. It's the Midwest where you've seen population decline that has led to nursing home closures. So I'm going to go back. That's nursing homes. That's pharmacies. That's hospitals. So it's not just population decline that's driving hospital closures. It's other stuff. Y'all have any ideas about what that might be? Don't want to talk today? That's fine. We'll get you to exhibit break sooner. I've got some ideas. We'll get to them. These are the specific rural hospital closures in Texas. We count 26 in 22 communities since 2010. That's more than any other state, possibly because we have more geography and more in the denominator than any other state. I think Tennessee leads the country in terms of percentage. As you can see, it's generally east and southeast Texas. The way you get 26 and 22 is some hospitals have closed, tried to reopen, and close again. So you had some communities, Bowie's the most recent example, where you've had a hospital close twice. And this is actually the Bowie slide. Their hospital closed after a failed hospital district election in 2020. The election failed by 3 votes. People thought that they were bluffing. They closed the hospital. And this slide actually comes from the economic development coordinator. Her name's Janice Crowley. And we always talk about access to care, how important that is, right? Janice from the Bowie EDC says, it's not just that we lost access to care and that we lost 100 good jobs. It's that our local sales tax revenue went down by 1/3 the year after the hospital closed. And then the enrollment at the school district dipped, which is the way schools are funded in Texas. So Bowie went through a round of teacher layoffs. We had homes that were listed for sale on the market in 2018 that are still on the market today. And we have businesses that were looking to locate to Bowie, but they aren't going to do that in a community where their staff can't have access to health care. So there's this domino effect. And so now we talk about, at the legislature, we talk about the importance of access to care, but also how hospitals are foundational to rural economic development. And that you have a hospital close in a community like Bowie, and you go back a couple years later, it's not just that the hospital closed, it's that the pharmacy closed, and then the clinic closed, and then the grocery store closed, and then the bank closed, and you realize that it was a hospital that was holding that community up. Does that make sense? This is shifting gears back to national, and this slide actually is from the Chartist Group, which is a national firm. It essentially shows across a number of factors a 20 to 30% disparity in elderly population, in mortality, in insured children or access to coverage, in access to primary care and access to mental health. I saw that there's a speaker that's going to zero in on mental health later today. The thing that's not on this slide that is actually, I say most things are negative, I think a good thing that we see that's also a disparity in rural communities is the percentage of rural citizens that enlist and serve and die for their country. There's a 20 to 30% excess of rural citizens that enlist to serve in the military. So this is not, the Chamber of Commerce folks don't like it when I say this, but when you talk about rural Texas demographics, it is generally older, poorer, sicker population that you're dealing with. And when you're talking about healthcare, that's a really tough recipe because it means Medicare, Medicaid, uninsured, right? We work against those things. And essentially, chronic conditions I actually think that's another one of the reasons that you see more hospital closures in the Southeast. And I'll show you a slide that actually I might show it pretty quick. But limited resources and chronic conditions, to me, are drivers of the strain on rural healthcare. This is actually from the CDC, talking about chronic conditions. Rural Americans are at greater risk of death from the 5 leading causes. And there's a statistically significant difference in all of those: heart disease, cancer, injury, respiratory disease, and stroke. And then you kind of start lumping these. This is more bad news. And I would actually put it into 3 buckets. You've got the demographic bucket. So we talked about older, poorer, sicker. You're talking about poverty. You get into the chronic condition bucket when you talk about things like this from the last slide. And then the third bucket, to me, and Chartis is actually starting to call this statistics of despair. But you talk about suicide rates, and it's scary, the disparity among farming communities or rural populations when you look at suicide rates. And then when you peel that back another level, I didn't put a lot of articles in here. You can find them yourselves. But when you look at that by race, suicide rates among black populations are 3 times what white populations are. And we got to do better than that. So there's demographics, there's chronic conditions, and there's despair. And we're seeing all of that play out in rural Texas. Anybody want to disagree with me? Here's the map that shows obesity. The lighter you are, the better you're doing. And I don't know what Colorado is doing right, but they are all yellow. Texas actually compares favorably to as you go further east and further south. Actually, when I see national health rankings, Texas generally does not compare favorably, but when a new study comes out, I basically say, thank God for Mississippi, because we're 49 instead of 50. But I think it's chronic conditions like obesity that drive a lot of the bad health outcomes. Here's cancer rates. And actually, when he was introducing me, Dr. Phillips mentioned the program that we got to partner with Texas Tech on while I was at the hospital in Childress. I actually got to work there for 16 years before I moved to work for the association. And I got to work all 16 of them with my dad, who recently retired as a rural family practice physician in Childress. One of those 16 years, he was actually the chief of staff, which was an interesting year, but it was all good stuff. Most mornings, he would stop by my office. Sometimes we get to drink a cup of coffee together, but I really do miss that. My parents were really angry when I moved to Austin because I took their grandkids with me. But they're getting over it. They even came to see us a couple weeks ago. We went to Amarillo. That's where our referral patterns were, and talked about how this is I say opinion. I'm pretty confident in this. I tell people that a cancer diagnosis, no matter where you live, is awful. It'll rock your world. But a cancer diagnosis that's for mood. When I say cancer diagnosis, the lights go down. A cancer diagnosis when you're 100 miles from treatment or care is even worse. And my friends that experience that tell me it's not the ride to treatment, it's the ride home when you just want to be in bed and you need to throw up. That's awful. So we actually started trying to make this pitch to try to do some limited chemotherapy services in Childress. And Amarillo said, we're busier than we can manage. We'd love to help you, but we can't spend 2 hours driving to do a 4-hour clinic. We did the same thing in Altus and Lawton, Oklahoma. And then we had a friend at Texas Tech, and my dad actually rode with me that day. I said, you want to go to Lubbock and help me make a cancer pitch? And he said, you think they're going to do it? And I said, I don't think they're going to do it, but I'm going to try. And we had a great conversation that day. One of the guys in the room was a cancer survivor, and he had a heart for it. Dr. Kobos was wonderful. We invited him out to Childress, and when he drove out, he said, I have guilt around this, but I have patients from Paducah and Guthrie and Matador and Childress. And I just thought they were around Lubbock. It's not until you get out in the country and drive to Dickens, Texas, that you realize how isolated these communities are. And it's not just my Childress folks, it's my people that are closer to Childress than they are to Lubbock. Anyway, we stood that up, and I said that I'm not that innovative. Of all the things I've ever done, that's probably the thing I'm most proud of. We had a speaker at our spring conference that said, I want you to think about something you've done in your life that you're most proud of. And that cancer program is what I thought of. The point he made was that that's probably something that's hard. You know, we aren't proud of things that we do that are easy. We're proud of things that we do that are hard. And I was having a tough week in Austin a couple weeks ago at the state legislature, frustrated with how things were going or not being able to get my way, which I throw a little tantrums about that every once in a while. And my mom screenshotted an article from the local newspaper, and it was actually Dr. Hardwick, Fred Hardwick, that had written a story. He had got some sort of unsung hero award, and he had deflected that credit to a chemotherapy nurse in Childress named Kathy, because the program is being recognized for being there for 10 years. And I didn't realize it had been 10 years. I actually called one of our cancer patients and got to talk to he and his wife and his son. I hadn't talked to him in 8 years, and found out that the son was a home health worker, and that the wife was becoming a paramedic. And I was just so proud of all the ways that program had touched people. But what we see generally, getting back to my presentation, is that even though incident rates of cancer are lower in rural communities, mortality rates are worse. So you have disparity, for whatever reason, tilted both ways. Less incident, more mortality, and I think that's because of the travel burden associated with cancer care and radiation, all the things that come along with that. So that's another disparity. This is a map from the National Rural Health Association, I can't take credit for it, that shows 6 or more chronic conditions, and it's the same sort of thing that I would suggest you lay over the top of the hospital closure map. But these are the challenges we face, not just throughout the country and in the Southeast, but in West Texas as well. This is a busy table, but it essentially shows for every disease or illness, the less you make in terms of income, the more prevalent these conditions are. So there's an income component to disparity as well. If you have hearing trouble or dental trouble, it's tied to being poor. We've got to work on that as well. I gave you the Texas slide on maternity desert. This is the national slide, and actually, as bad as we tend to think things are in Texas, it's worse in some of those states to the east of us. So these are the pressure points for rural hospitals that I work for. We talk about death by 1,000 paper cuts. COVID-19 was mentioned in the introduction. You know, there were times when every bed in the state of Texas was spoken for, and we needed more bed capacity. And there was federal stimulus funding that was sustaining for rural hospitals and providers, but that actually ended in 21. And I would argue that in 22 and 23, our vulnerable rural hospitals are actually even more vulnerable than they were before. And if you actually track, I don't have this graph, but if you track mortality throughout the pandemic, rural populations trended pretty close to urban populations throughout the pandemic until you had surges and you couldn't get patients to a higher level of care. And there were times during those surges that rural COVID mortality rates were actually double urban, and that breaks my heart, but many in the room dealt with that. So this is the last map, I think, in my presentation. It actually shows life expectancy. Speaking of breaking your heart, we think that outcomes, health outcomes, should not be tied to place, right? And what we find in America is your zip code or where you get your mail does as much to determine your mortality as any other factor. And we've got to do better than that. These next 2 or 3 slides are actually, it's art, and I have to credit a friend of mine at the Colorado Hospital Association, but an artist named Andrea that takes these speeches and converts them into art. And this is my way, I think, of transitioning to more of a solutions posture around rural health disparities. What this says is every voice is heard. We find solutions when every voice is heard. When I got to Torch, we actually argued for rural reporting exemptions when it came to quality, when it came to patient satisfaction, and said, we've got low denominators, we shouldn't have to report. I actually argue against that and for more transparency, because I think, I used to say, what we measure improves, what we measure and publicly report improves faster. And we do have low denominators, but it's easier to hit 5 free throws in a row than it is to hit 1,000 free throws in a row. So I actually encourage more transparency, more accountability, no excuses, show and tell type approach. And I think that even though in some areas, in some communities, and there'll be good justification for it, we should be a little bit embarrassed by our performance when we actually look at it. But the other essential part of that, excuse me, is no judgment or blame around that. It's about fixing it. It's not about assigning blame. We've got to do better. This is the other thing that they spoke about and wrote or drew about. I think the way ultimately we get to solving some of these problems with disparity is within the layers of the organization. I actually went back and checked my work on this for my time in Childress, and I'm not sure that I would give myself a passing grade. But you need frontline staff and clinicians that look like the community that they're serving to get over rural health disparities. I think maybe we do okay there, but there's room for improvement. Within my leadership team, I had a C-suite of 4 people, and there was no minority representation within my C-suite during my time in Childress. 2 of the 4 were female, but we were not diverse. And then I look at governance. About 2/3 of those 160 rural hospitals are independent entities of local government. They're hospital districts with an elected board. And when we look at the governance of our rural hospitals in Texas, it's overwhelmingly old white guys, right? And when I look at my board in Childress, we were all white and we had 1 female. So I had to give myself a failing grade there. Now, in my defense, I actually actively recruited because I knew that was an issue. And when we had a turnover or elections, I tried to have conversation, encourage people I knew that I thought would be good to run. Maybe they were wise enough to not want any part of serving on a volunteer board, but I could never convince someone to run for an opposed seat on our board. But you get the point. Until our boardrooms look like the communities that we serve, I think we're going to be battling this gap in equity in healthcare. We've got to do better there. And I'm not talking to you, I'm talking to me too. Here's the last piece of artwork that I really like, and it talks more about, stop pulling on the thread and start patching the fabric of our communities back together. I used to tell people that some rural communities, we actually usually got along in Childress, but some rural communities are their own worst enemies. And if the city council can't get along and the school board can't get along in their boardroom, how in the world do you expect them to succeed outside of the boardroom? Restore the fabric that connects us. So this is my thoughts. Last 2 slides about how we do that, and I'll have time at the end for questions. The first, kind of like 12-step program, you admit you have a problem. The second, I think we've got all this data and information, but we aren't really aiming it at solving our problems. I'll give you an example. When we put electronic medical record in our clinic for the first time, we had the insight or the ability to query things from the system that we would have had to do manually before. And so we just picked one. And we looked at within our clinic, and we could break it by provider. We looked at diabetic A1C and foot exam rates by provider. And when I got it, we had about a dozen, like 10 or 12 providers in the clinic, and most of them were kind of clustered together, maybe a little bit above average, and we had one outlier on the low end. And I thought, how should I deal with this? And then I thought, I'm just going to send them the report. May not have been a good idea, but I said, hey, we're learning some tools we have within this new record. We think these things matter, and we wanted you to be able to see how you're doing. And I sent it to them, all of them, and in a way that they could see their peers. And within 15 minutes, my phone rang, and one of our physicians said, you don't understand how sick my patients are, and you don't understand how my practice is different, and that should be adjusted somehow. And I said, maybe it should. It's not a perfect report. I'm not trying to pass judgment. I just think it's interesting that we now have the ability to look at this by provider, and I'd love to see us improve it, not just you, but all of us. And he was frustrated, but he kicked me a little bit, and we hung up, and that was it. Well, the next quarter we ran the same report, and guess what happened? He was in the middle of the pack. So it's a little bit of hard conversations, but it's a little bit of necessary conversations. And the thing that I wish I had done was go a step further, even though I probably wouldn't have liked the results, to say, we can show this by provider. Why don't we show it by provider, by race? Why don't we show it by provider, by gender? And just see what it shows. I never did that. I don't know what it would have shown, but I worry that I would have been a little bit ashamed on our performance. And when you get into practice, now that we have all these tools, I would challenge you to go back to your organizations and institutions and just pick one. Just pick something and see if you can't slice it a couple of ways. Not just to call providers out, and really not even to try to have a showdown. It's just to understand that things that we would never think we would do intentionally, these are good people. Nobody goes into rural healthcare. I can't imagine a nurse going into nursing school in rural healthcare without a heart for helping people. And I don't think they care what that person looks like or acts like. But somehow, through the systems we've always had in place, we get disparate results. And we shouldn't be okay with that. So I challenge you to go back, try to run a report, and just see what it shows. If it shows that you're stellar and that your minority populations are getting just as good a care as your white populations, congratulations. But I don't expect that's what it's going to show. And we've got to do better. Does that make sense? We talked about clinicians. I wish I had recruited different. I recruited about a dozen physicians when I was in Childress. And most of them looked like me. Most of them were from my area in the community, but didn't really look like the people that were in our clinic. Same thing with the boards. And then it's just got to be a priority. There are 1,000 things that you could go back and work on in your office, in your career. I think we've got to make health equity and disparities and value a priority in a way that we frankly haven't in the past. Does that make sense? I did an interview, and this is actually my next to last slide. I did an interview a couple of weeks ago, and the reporter asked an interesting question at the end of it. She said, if you had a magic wand, what would you wish for rural Texas? And I did a terrible job at answering that. I'm one of those people that somebody asks me a question, and I stutter and fumble through it, and then I lay in bed at night and think, I wish I'd said, I wish I'd been quicker on my feet on that. So I was not very good in that moment, but I thought it was a good question. And I went back and made a list that if I had a magic wand for rural Texas, what that might look like. And I came up with Every Texan Matters. There are 30 million Texans. Seems like about half of them are in Harris County. But there are 3 million rural Texans. That's essentially the population of Arkansas spread over the land geography of Arkansas, New Mexico, Oklahoma. But rural Texas would be the 34th largest state. And we think of Texas as a rural state. It's not. It's a very urban state. But we gotta live up to Every Texan Matters, even those 3 million that are separated by miles and miles in West Texas. 89% of Texas lives east of I-35. I work a lot for the people on the west side of 35. My second and third things are linked. 99%, I'm not sure we can get to 100% or perfect, but 99% of Texans live within 30 miles of an ER clinic. Telemedicine is awesome, but I think having a local family medicine physician is better. And then 99% live within 60 miles of a hospital and obstetrical services. I'm making the distinction between emergency room care and primary care, and then hospital and OB. It's hard to spot a maternity ward within 30 miles of every Texan, but I think we ought to be able to get within 60 miles. Our mantra at Torch is we're better together. We're trying to do things together that any of those 158 rural hospitals would have trouble doing on their own. There are a handful of them that can do anything they want. Most of them need the power of aggregation in the group to find a path together. I mentioned primary care. That's the future. You know, we got to play offense instead of defense. The trend in hospitalizations, inpatient, is, with the exception of COVID, declining. Most rural hospitals tell me 80% of their revenue is outpatient already. That's only going to increase. And the way that we control healthcare costs, I believe, in the future and bend the cost curve is through primary care with those chronic conditions. Mentioned innovation. I don't know exactly what that's going to be or what it's going to look like, but as we get better with broadband coverage in rural Texas, we've got to innovate because you can overcome geographic barriers through technology. Not perfectly, but better than we've ever done it before. We believe health equity should be a strategy for hospitals, in a pillar, the way some of those foundational structural focuses have been, but equity hasn't historically been on that list. So we've got to make it a priority. I'm not going to step on the afternoon session around behavioral health, but that's been exposed as the invisible challenge. We've got to do better as it relates to behavioral health challenges. And one thing that really is a rural advantage, and I'm not knocking on my friends in urban areas, but when you're at a system hospital in an urban area, and I'm not necessarily talking about Lubbock, I'm talking about Dallas, Houston, San Antonio, there are like 30 levels of supervision. And some of them, it's not even in Texas where decisions are made, it's Nashville, Tennessee, or wherever. And you can't get anything done, even if it's a good idea. In rural Texas, in a clinic or hospital, during COVID, we saw this. If somebody had a good idea that morning, it could be implemented that afternoon. That is unheard of in urban areas of the state. We call it speedboat instead of cruise ship. Does that make sense? Turn a cruise ship takes a long time. Speedboat, you can cut on a dime. And so we think that speed and agility matter. That's my magic wand list. If you have suggestions for my list, I'd love to hear them, and I'd love to have a longer list. I actually have to fly back to Austin tonight, but I'm going to be here for a few minutes. That's how to find me. But I'll also leave some business cards on the table, and I really would love to meet you if I haven't already. It's good to be with so many friends in the room today. But I'll hang around for a few minutes during your exhibit break. But thanks once again, Jad and Reagan, for having me here. It's been a pleasure.